Hello and welcome to our webinar today. My name is Shyla and I'm the CEO of Palliative Care South Australia. And I'd like to start today by acknowledging that it's National Palliative Care Week. So happy National Palliative Care Week, everyone. And thank you for taking the time to watch this webinar and for anyone that might be watching it after as well. So I'd like to start by acknowledging the traditional owners of the lands of wherever we are today and pay respects to elders past, present and emerging. Recognise anyone in today's webinar, any of the speakers or any of the participants who have First Nations heritage. And also to acknowledge that sad news and sorry business happens on the lands and seas around us. It takes a community to look after each other, and the Aboriginal population has an amazing amount of knowledge, history in this area that we can all learn from as well. I'm delighted to say that we're partnering today with Country South Australia Primary Health Network to support us to have this conversation in the country areas and really focus on this topic for regional South Australians. So thank you so much, Country South Australia for PHN for supporting this. So this is a webinar with Zoom. Many of you guys are probably pretty good at all these IT platforms, but anyway, I'll just do a quick prompt for everyone around how it all works. So there's a Q&A button and a chat button. So you're welcome to put any comments in either of them and I will be able to monitor them for you. We will be having our wonderful different speakers giving their own presentations at first. So they'll go through their presentations and you feel free to pop anything in the chat or the Q&A, but we'll wait till the end to do any questions and answers. We do know that some people have kindly already asked some questions and we thank you for that. If there is time, I'll be asking these questions to our experts. If not, we will be able to send you some of that information directly to the people that have asked as well, so we can follow you up that way. Okay, well, I'm delighted to have these beautiful speakers with us today. And our first speaker is actually Jason Gabriel. Jason is from, many of you may know Jason, he's a palliative care nurse educator in the Regional Hospice in RACF project. He's been doing some amazing work across the southeast area of South Australia and is very knowledgeable around education in this space. So I hand over to you, Jason. Thank you so much.
Thank you, Sharla. Thanks very much for having me today. Happy to present. So I have to talk quite quickly due to limited time. I could present this for a long time and perhaps even some of the subjects or issues and topics I raise could be presentations on their own. So forgive me if it feels rushed, but I'm happy to talk about anything in more depth afterwards or via email or any other communication platform. So I better start. So let's go to the beginning. So addressing palliative care needs in country communities, what's your plan? And hopefully I have some for you. Country South Australia, the private health network have needs assessment report that's just come out 2025-2028. Their key points: ageing population with high burden of life-limiting conditions requiring palliative care. Several populations have unique health needs, major data gaps in palliative care access and service delivery across jurisdictions. There are widespread impacts of life-limiting disease across the community, and their identified needs are improve awareness and access to patient-centred palliative care and reduce avoidable hospital admissions. That's the key point. Locally relevant professional development and education for primary care clinicians. You can see the little maps up there of South Australia. We've got the remoteness areas and the relative socio-economic disadvantage coincides. Obviously, the more remote we get, so those maps do have a connection, as you can see. Next slide, please. Country, the needs assessment report, they identify priority groups within the SA region. So it's Aboriginal and Torres Strait Islander people, LGBTIQA+ communities, people living with dementia, people living alone, young people, culturally and linguistically diverse communities, people with disability. And the same map is presented here with the 6 health networks across South Australia. And the RSS supports all 6 LHNs. So you could colour that whole map in maroon, and that's the RSS. Next slide, please. So you can use tools as guides, thinking about goals of care, especially for regional rural areas. Use conversation tools as guides until you become more comfortable with your own language to have these conversations. The Modified Serious Illness Guide is used to help explore values, fears and care preferences, document goals of care and care plans, advanced care directives, resuscitation plan, 7-step pathway, and remember to honour cultural needs. Involve Aboriginal health workers for First Nations persons and interpreters or multicultural support for culturally and linguistically diverse communities. Next slide, please. So SPICT or SPICT for All also comes in many languages, which can be used with clients. Recognising dying for timely referrals, ask the surprise question. That's the first thing. Would I be surprised if this person died in the next 6 to 12 months? Yes, then it's time to talk. So use the SPICT tool, SPICT for All, or other tools. There are the palliative care collaborative outcome assessment tools to spot indicators of decline. So weight loss, frequent hospital admissions, identify when a patient is approaching end of life, worsening functional status, escalating symptoms, eating less. So use of simple tools, they identify and aid the need for early referrals. Don't wait for crisis or final days, especially in resource limited areas. Next slide, please. So the Modified Serious Illness Conversation Guide, it's a recent project within the Rural Support Service, and it's adapted from the known international serious illness conversation model, and it is modified for use in regional and rural South Australia. It's awaiting formal publication, but it incorporates cultural feedback by the Action Aboriginal Consumer Group and regional clinicians. So it's approved. And their research found the chronic disease nurses across the 6 LHNs reported uncertainty about how and when to initiate goals of care conversations, primarily due to low confidence and a lack of evidence-based guidelines. It supports clinicians working in isolations in particular, and it's a great tool for less experienced staff. Next slide, please. So here's the first step. This is to be used with the SPICT tool that I mentioned before. Does it meet 2 of the SPICT general indicators? Or 1 of the SPICT clinical indicators in order to initiate these conversations. Next slide, please. Section 2, it's very simple, just consists of key steps to guide the conversation. There's the 5 steps. You only need to use 1 or 2, not all of the steps. It just aids developing your own language style. Once you've used this tool a few times, you can probably not use it. You can file it away and you'll have by then your own language. But this guides you to use the appropriate language that you should be using. And then documentation and communication, putting those communication outcomes in the advanced care directives, documenting the 7-step pathway, and then letting the GP, specialist services or Aboriginal healthcare team know the outcome of that. Next slide, please. If you're uncertain, Palliative Care Connect, give them a call. You'll hear a little bit more about them shortly, but that's where you go. If you don't know, statewide, you phone this number, and that's clinicians to families. Thank you. Next slide, please. So Country Referral Unit, I put this up because this is where the allied health, all the multidisciplinary departments within the state, this is where you can go. You can phone the Country Referral Unit and get some information. Know what your local resources have available, and you might be surprised. There's community nursing, there might be a specialist palliative care nurse there as well, diabetes nurse, physiotherapy, occupational therapy, dietetics, podiatry, social work, speech pathology, community mental health, particularly home support services. These are all available through the Country Health Connect referral form and by phoning the Country Referral Unit. Next slide, please. It might not mean you just do a palliative care referral form. So both of these forms complement each other, but it's good to know what you have available in your local area. 3 criteria for palliative care. They have a progressive life-limiting illness. Their decision maker or the patient themselves, they understand and they have agreed to that palliative care referral, and their primary goals are for controlling symptoms, maximising function, and it's about quality of life and providing comfort. It's not a discharge form. If somebody's in hospital, this palliative care referral form isn't to be used as a discharge form solely on its own, because it requires a triage from a specialist palliative care clinician to phone up and then triage that referral to identify the needs and the reasons behind that referral. So early referrals for areas with limited resources is highly encouraged. Next slide, please. Dementia supports, regional and rural statewide. Many supports sit outside the specialist palliative care and can be accessed directly. Use them to build a holistic care network within your regions. We have dementia support pharmacists. Anyone can refer, identify a need where someone's not coping with their medicines. Deprescribing is complex and they can provide multiple follow-ups, which is the point. They want to be providing those multiple follow-ups. They prefer face-to-face, that's their preference, and they can do telehealth secondary to that if needed. Then there's the Nightingale program, work very closely together, and it's a palliative model of care provided by a specialist interdisciplinary team, and they have strategies and advice to support people living with dementia and care providers with a focus on promoting choice and wellbeing during the advanced stages of diagnosis. There is a criteria, but phone the National Dementia Helpline on this 800 number, and just state the referral is for the Nightingale program and with as much detail, with as much detail as possible. Next slide, please. The South Australian Virtual Health Service, SAVIX, is staffed by an MDT team. They have the ability to consult virtually or navigate to the most appropriate local care service, including the usual GP, for hospital avoidance services, urgent care service, or a physical emergency department. The statewide service provides an individualised assessment service via video link for urgent patients on scene with SA ambulance crews, regional clinicians, or aged care staff. About 70% of their clients have avoided admission to ED and instead receive individualised care in place or via more appropriate services in the community. Great for keeping older residents at home and out of ED and acute care settings. So do use this particular resource. The link's down the bottom there, particularly for before you call 000. Next slide, please. And I've just said virtual multi-D team, provide assessment and advice, re-accessing the most appropriate local service. About 70% of consumers avoid ED admission, and they're not 24/7 at the moment. They are 8 till 10 p.m. at night, but they are 365 days a year. Next slide, please. There's also the older persons mental health specialist services staff. Specialised service, that's for rural and remote mental health service, but always good to know that they're there. So there's their resource and their contact number. Next slide, please. Parkinson's disease. The RSS provides an advisory service. The role focuses on improving the care of people with Parkinson's in regional South Australia. The nurse consultant has specialist knowledge, provides support, advice, education, and links to resources and specialist services. It is primarily as an advisory service, but they can help you bridge those gaps and provide you with the resources and supports that you need. There's some really important links there. One in particular for prescribers, the medications to be used with caution. The Lara's PDF there's of interest. Next slide, please. Needs rounds. The aim of the regional hospice in regional aged care facility project is to improve access for regional RACF residents to receive palliative care services when they require them and to be cared for by aged care staff, so have training in good end-of-life care principles. This project includes escalation of care pathways, specialist palliative care support, workforce education to ensure the state-owned RACFs in the regional LHNs are equipped to internally manage end-of-life care within the facilities. And then we also have, in addition, the Palliative Care Link Nurse Program, and the Palliative Care Link Nurse serves as a liaison between the specialist palliative care services, RACF staff and residents, enhancing workforce capability for individuals whose goals align with the palliative approach. We do roughly weekly online education, series of education, and we also promote these supports available within the RACFs. Needs rounds is a clinician support service. That's something to remember, and the links, the email for more information is down the bottom, or more information is available on the government SharePoint side. Next slide, please. Excuse me. We have some public and healthcare staff resources within RACFs that we provide, in particular of good use, last days of life. Nurses find very handy to use for information for themselves and to share these resources with families and loved ones when someone's approaching end of life, and the grief and bereavement information. Next slide, please. Bereavement Navigation Service, statewide, helps people of all ages connect with bereavement and grief information and available support. Services are available by telephone and telehealth, that's statewide. And then they also have the Adelaide Metro, Riverland, Limestone Coast, Whaler and Port Augusta. Face-to-face is a possibility. to speak with a bereavement navigator, call that number. Bereavement navigation service is part of Palliative Care Connect, which you'll hear from shortly. Next slide, please. Voluntary assisted dying. Worth mentioning, it is mentioned here, it must be clearly understood, VAD is not palliative care, nor is it suicide. However, autonomy must be respected, and it does neighbour us. And VAD was implemented in South Australia in January 2023. Each state has its own specific guidelines. So in South Australia, VAD cannot be raised by clinicians, and there is a preference for self-administration or administration by a medical practitioner only. However, they highly encourage, if anyone within your care has mentioned this service, to just phone during the navigator service and they'll go from there. Very supportive, very wonderful service, and they'll help you with any need you have with regard to this topic. Next slide, please. The support line for clinicians, GPs and locums in isolated areas and hospitals. Do call this number. You just have to do an ISBAR handover, discuss your palliative care caseload, and then you can get all that advice for complex prescribing for your inpatient or community care patient or within your GP, whatever setting you're in. They have a very strict criteria on who can call. So GPs preferably, community palliative care teams, the level 2 specialist palliative care, nursing staff and above, and particularly medical staff, GPs and nurse practitioners to do that, because it's really prescribing advice. But it is available 24/7. You'll just be asked what area you're living in, and then you'll be put through to the on-call registrar consultant to discuss prescribing. And that can save a lot of time. You don't necessarily need to do a referral to palliative care. You just call this number and you have your answers then and there on the spot. Next slide, please. Also, a little bit of training for those people who are isolated. Syringe driver use. It's on the GPEX website. I've got the link down the bottom. Palliative care, palliative medication proficiency. It's a wonderful 2-hour course, and it just gives you a lot of comprehensive information about syringe driver use and opioid prescribing for GPs and palliative care nurse practitioners. I put a link down in there for the Queensland site as well, which has a lot of information or short videos with regards to using a NICI pump, which can help as well. Next slide, please. Here we've listed some at the start what was identified, and it's with our minority groups again. So the Aboriginal and Torres Strait Islander people, the caring at home resources are fantastic to use. Go on their website and have a look. And there's also the Gwandalin Palliative Care. There are many others. I only had room here today to put 2 up. So these are the 2 I chose, but all of the others are just as good. There's plenty of resources there. I'm happy to provide you with those if you require any more after. And the culturally and linguistically diverse communities, they have a great website. You can go on there. There's palliative care conversations available in 11 languages. So have a look there. LGBTQI plus communities, they have a link down the bottom here. They actually have palliative care end-of-life training. So go on there and have a look to see what they have. I flagged the NDIS for the disability services because they have a neurodegenerative palliative care and rare diseases advisory group. So have a look through their website. And once again, if in doubt, and if I've missed anybody here, due to limited time space, I've added Palliative Care Connect, because that's who you call when you don't know, or even if you do know, call them as well. Give them a call to have a discussion about your need within South Australia regional rural areas. Next slide, please. So this is the latest published November 2024. It's the Country SA Private Health Network Needs Assessment Report. Get your eyeballs on that. It's very good. It's well written, very good reading, but it identifies in unison all the areas that we need to know about within country and rural. So I advise you go on that link down the bottom, which will provide you with all these links that are in the slides. So have a read of that resource there. And next slide, please. There we are. Thank you for listening. There's my contact details if you would like any more information. Thank you.
Thank you so much, Jason. And I think that is just so lovely to see how much support is available in this space and that it is accessible across the country areas. So thank you. And to see how approachable and supportive Jason and his whole team is like this, very keen to help to activate and support people, anyone across the country areas that has palliative care needs, and to support all the teams that surround them. So thank you so much, Jason, for that. Okay, so now I'm delighted, and it's quite a lovely segue actually, Jason, because you spoke so lovely about the Palliative Care Connect service. We're very lucky in South Australia to have this navigation model across the state, and we're delighted now to have Miles from the Palliative Care Navigation, and following this will be the Bereavement Navigation. So Miles will talk about their team and what they do and can offer in this space. Over to you, Miles.
Thanks, Charlotte, and thanks, Jason. I got to say, having been a social worker in Power Care for 6.5 years, Jason really has distilled down like all the stuff I've learned over that time. He's really given you his gold. That was amazing to see all that condensed. That's a cracking job, Jason. Yes, Palliative Care Connect has a couple of branches, and one of them is the statewide Palliative Care Navigation Service. Originally, we were set up to be like a non-clinical sort of gateway to steer people in the right direction if they had a life-limiting illness. Navigators are referrers to the Metropolitan Referral Unit, so we have the capability to send in community nurses when a person does not need specialist power care, but nonetheless would benefit from symptom reviews and checks. Over the last 18 months, so we've sort of noticed that we're sending nurses for psychosocial reasons, and we've started attending aged care homes as well to support people. So we've noticed that really a lot of our work has become supporting or having or facilitating conversations with people out in the community over the phone or in person around their goals of care, essentially, or their advanced care planning. And that goal of care setting or talking about this stuff early on and this advanced care planning really supports specialist teams. So I want to talk a little bit today about goals of care and advanced care planning. These are some of the things I've noticed anecdotally from, I don't work in rural areas. These are some of the things that I've noticed, and Jason spoke to some of these already. So I'll have the next slide, please, Casey. So I want to chuck in a little bit of a chat about goals of care. So look, all of us, if we're in palliative care spaces or end-of-life care or in hospitals or practitioners in healthcare settings, all of us to some degree are having advanced care planning or documenting advanced care planning or goals of care. So I want to see I want to just sort of discuss what that looks like in a conversational way, how people talk about it in the community, and how it ends up getting documented in clinical sort of speak. So may I please have the next slide? So what I tend to do is have open-ended questions over the phone. I mean, all of us navigators do, which kind of are designed to sort of elicit people getting to think about what it is that they want in terms of palliative care. Where do they see themselves dying, and where do they see their ceiling of care being? So I might ask open-ended questions like, what, if any, would be the one thing that meant that you can't be home alone anymore? Or how would you know that you're not coping anymore? Would there be any signs that told you that you'd need to change your plans? Now, there's going to be different responses to that. Some people are going to go, no, there aren't going to be any signs. No, I'm going to be perfectly fine. Or no, I would like to die in my bed, thank you very much. But some people will say, do you know what, actually, I think if I couldn't get out of my recliner, that would be a concern. That might make me think I need to explore aged care home. Or some people say, do you know what, once my husband is fully incontinent, I don't think I could cope. So having these sort of open-ended discussions with people early on, we can all do, right? And so this word goals of care doesn't need to be a highly clinical term. It can be a conversational process. And a lot of these times I'll couch these or lead or I'll prompt people. So if people are, they're pretty resistant, I don't really want to talk about power care. Power care means that I'll die, or I might have a very gentle couched conversation. In other words, other people tell me that they worry about a future when they can't lift somebody anymore, or they're worried about hurting their back, or they're worried about their husband being incontinent. Does that sort of stuff ever worry you? Now, a woman might turn around and say, no, it doesn't worry me. I'm adamant to stay at home for as long as possible. Great. Now we've got this position of the family of where they want to go and what their goals of care are. So whether or not they agree or disagree, this all informs our goal setting. May I please have the next slide? So this informs our goal setting in terms of end-of-life care wishes. And those of you that are familiar with the Advanced Care Directive in South Australia in particular, these sorts of conversations set up how we might support people to document their legally binding parts of their Advanced Care Directive, such as their SEM and the Part 4 binding refusals of care. These sorts of conversations, these open-ended conversations might prompt people to say, and I'm remembering a time where a woman said to me, it's really important to me that if I'm dying or if I'm in PAL care or if I'm in hospital or if I'm in aged care, I want to make sure my hair's always beautiful and my lipstick's on. I know this sounds weird, but this really helps us support people to go in the right direction, all of us. It also helps us in terms of discharge planning at the pointy end, in those of us in hospitals. These open-ended conversations that we have, all of us can have. A person might tell you, do you know what, if I do have to go into care, I'd like to be close to my sister. Where does your sister live? Down by the beach in West Lakes or something like that. That helps us with discharge planning. It helps us with goal setting. It helps us with our Advanced Care Directive. It helps people feel less frightened and plan for the future in really gentle ways. May I have the next slide, please? Now, how does that look in clinical parlance when you're actually looking in Sunrise EMR? It's very common to see it just written really plainly. And a 7-step pathway, for example, those of you that write them or read them or in aged care homes have them printed out, or maybe you're a social worker and you've got one popped on someone's fridge. It just says not for CPR, intubation, ICU, treatment of reversible conditions, or MER calls only. That's pretty common actually in PAL care, but just that sentence, I would hazard a guess, it's probably the most common thing I would see written. And in terms of discharge planning, all of us are, those of us who work in hospitals are under immense pressure to get people out of hospital as quick as possible, in line with all of those open-ended questions and those values and those ethics that people hold dear. And we want to succinctly put that down as stay at home as long as possible, or family committed to end-of-life care at home. So that's how you might see the end product in clinical settings from open-ended questions that we all have the ability to have with people in the community. Can I have the next slide, please? Recognising and explaining dying. So as a palliative care social worker, it's not really my job to prognosticate. And from the palliative care specialists, doctors and consultants that I've worked with, no, they often say nobody can prognosticate. Nonetheless, I think because this is such an ongoing question, when is my loved one going to die? Because that's such a big question that all of us have been exposed to at varying degrees, I have found it useful to describe to people not when somebody would die, but what they may expect. The key caveat being may, because sometimes people just suddenly die, and that can always be a bit of a shock for all of us, even in PAL care. So I would describe to people, you would expect your grandma to be sleeping 20 hours a day, and you would expect her to not eat and to not drink. And I think that also supports a lot of residential care staff too, because there is an expectation that their loved one's starving to death, or that they suddenly need an IV drip because they saw that in a movie, or that they might need subcut fluids under their skin because they can't drink anymore. Now, having these supportive conversations that that the GI tract slows down and people don't need food at end of life, that actually really calms people down, calms the families down, and it actually supports our patients, because nobody needs water under their skin when they're dying. Nobody needs that. It's just going to make them feel uncomfortable. So I find it useful to not prognosticate, but to explain to people what dying might look like and what they might expect. May I please have the next slide? Yes, it's important to refer as soon as clinically indicated to specialist PAL care, but going off the back of what Jason was saying, it's also important to understand the limits of specialist palliative care teams. Now, I'm not talking about palliative care. Palliative care we're all involved in, but I'm talking about specialist PAL care teams. They're really there to ensure that symptoms aren't unmanaged. So what's really important in terms of supporting people in the community with power care is understanding the overlapping nature of how all the services interweave to support people. So we want to make sure people are registered with My Aged Care. We want to make sure to some degree that people understand that there's a wait list, and while they're waiting for a home care package, they'll have a CHISP code. We want to let them know that they can register with Care SA, the Cancer Council, Dementia Australia, just like Jason was talking about before. We want to explain the ceiling of care, and what do I mean by that is, you know, I might say to people 2 or 3 times a day, even with a level 4 home care package, unfortunately, often that's not enough to keep people home safe and independent. You know, it would require the 24/7 support of family. And if you're not able to do that, that makes a lot of sense, because that's the way our societies are structured. So if that were the case and your mum needed full overnight care, what do you think you would do? Oh, I hadn't thought of that. Perhaps we do need to think about an aged care home. Okay, great, I can help you with that. So I actually think limiting people's expectations to some degree about what power care is also a supportive thing to do. So referrals to power care doesn't just mean sending off that form. It means making sure people are connected to all of these community supports. Also going to great lengths to make sure that people know the ongoing prescribing major role of the GP. The oncologist isn't going to keep filling that script for endo. Don't run out on a Friday, because that's going to, you know, present in a pain crisis. You're going to end up in hospital. So the GP is a really important resource, and explaining that to people is a huge part of our work as well, strangely enough, for such a simple thing. They're the ongoing prescriber, and it's worthwhile having regular appointments booked with your GP. And if you don't like your GP, let's help you find a good one. And explaining the consultancy role of power care, that they're there for symptom management. They're not going to do day-to-day care. That supports our teams, that supports our specialist power care teams, and it also makes sure that we're reminding people of the holistic nature of power care, that it comes from all sorts of services. Next slide, please. Talking to carers about their experiences, in the vein of what I was sort of saying before, I think propping up our carers is fantastic, making sure that they get a lot of support. But I also think that giving, so I've heard this described as giving people permission. Perhaps that's not the right phraseology, but letting people know that it's okay to fail in the caring role, that other people can't do what you're doing. So I use open-ended questions. You know, what do you think about the fact that 7 out of 9 carers are women? And some women will say, you know, I might say to them, what do you think of this statistic? Is this fair or not fair? What do you think about that? Some women will say, I think that's fine. That's my duty. I want to do this. And some women will say, do you know what? That's not fair. But why should I have to do all this work? I am struggling. I thought I was all alone having to do this. I didn't realize all these other women were struggling as well. Maybe I do need to consider an aged care home. In other words, propping up carers is fantastic. It's part of our job, but also letting people know that they don't have to suffer in silence, and that there are other mechanisms in place, such as aged care for their partners, is another supportive way to go. All right. So these are some of the questions I might ask carers that would elicit this sort of support. All right. So yeah, may I please have the next slide? Consultancy role of specialist palliative care services is one of the ongoing conversations we have with folks. I need a specialist palliative care team, and they need to do day-to-day nursing. Again, we go back to that, explaining to people this support network and building support teams. And I think really in the context of today's conversation, in rural areas, it's probably even more important to understand how support teams work. So your support team might be your friendly neighbour. It might be recruiting the family that live nearby to start making a roster to start supporting mum and dad. It's ensuring that people are connected to all these different services. It is not just a referral to specialist palliative care. It really just lets people down, and it really hurts them in the end. So I think limiting people's expectations it sounds cruel from the outset, but it actually pays dividends down the road, because we want to let people down very gently. And we want to wrap them around with as much care as possible. But sometimes I see people thinking that palliative care team's going to swoop in and save the day, and then they get incredibly distressed when they learn that that's not the case. So we play a tremendously supportive role in explaining how all of this fits together, and explaining the limits of some of this care. So I hope that's clear to people, that I'm not a cynical, horrible social worker that tells people they can't have things. Can I please have the next slide? In summary, palliative care isn't just about referring to specialist power care. We all contribute to patients and carers to be clear on their values and goals and we can use curious, open-ended questions. You don't have to be a social worker to do that. Explain the critical role that families play in palliative care, and also acknowledging some people don't have families. Okay, so let's think about how we can support people who don't have next door neighbours, who are estranged from families. That happens a lot too. We support carers by open-ended questions and not necessarily forcing them into the caring role by propping them up and propping them up and propping them up and burning them out and breaking their backs. It's okay for carers to not have to care for people anymore, just as it is for them to stay in the caring role. Let's be transparent early on that level 4 home care package isn't always enough. Let's explain that aged care homes are capable and specialised these days in palliation and end-of-life care. People don't need to come into hospices for end-of-life care. So yes, we want to honour people's wishes to stay at home for as long as possible, but let's not frighten them that that's the only place that they will be happy and supported. So I think I hope I've made a good case there that it's supportive and less distressing for families to have their expectations minimised. I hope I've made a pretty good case there. And let's build support teams around people. So whatever that looks like for people, usually asking open-ended questions helps you to understand what those support teams look like, whether that's a neighbour, whether that's a family member or not. I think that's the end of my discussion, so I'll hand back to you, Charlotte. Thanks, everyone.
Thank you so much, and thank you for showing how you can have these conversations compassionately and really listening and providing the space for them to answer you in that area as well. So you can see how accessible Palliative Care Connect, the navigators are, and thank you for those examples as well. So now I'm delighted to introduce James. Many of you across the country area probably actually know James with the Focus One Health team, and they lead the bereavement navigation part of Palliative Care Connect. So over to you, James.
Thank you so much, Shyla. So thank you for that introduction. My name's James. I'm from Focus One Health. I'm based in Berry. I would like to talk a little bit about when should bereavement support begin and what does good bereavement support look like. But I'd like to start by throwing the net pretty wide. If we could go on to the next slide, just to provide a bit of background. So every year in South Australia, 15 to 16,000 people die, of whom about 80% die in a hospital or residential aged care facility setting. I was really interested to hear Jason phrase before the surprise question about would I be surprised if this person died in the next year? More than 60% of those deaths that are occurring can actually be predicted. And the other thing that jumps out from the literature is that 40 to 70% of people dying in South Australia from life-limiting illness would actually benefit from palliative care. So if we jump over to the next slide, in terms of shapes and sizes, at the moment, there is about 100,000 admissions into hospitals per year in Australia with either a primary or secondary diagnosis of palliative care. And about 57% of those admissions were end of life. And on average, people will have 3 admissions in the last year of life in the course of their palliative care. I think it's universally recognised that hospital can be a suboptimal environment for delivering end of care life. It can be noisy, it can be disruptive. You've got people coming and going, but the trend is actually on the uptick. So there's, in South Australia at least, there's been almost a 30% increase in hospital admissions for palliative care between 2015 and 2019. Interestingly, some of the factors that are associated with an increased likelihood of having end-of-life care delivered in a hospital setting are actually socioeconomic disadvantage and rurality. So with that sort of as our very broad background, I'd like to jump back a little bit in time and talk about my acculturation to end-of-life care as a nurse in the regions. So thank you, if you could advance to the next slide. So a long time ago, when I was a mature age nursing student, I was taught at uni about the Kubler-Ross model of grief. which has probably got some people in the webinar shaking their heads. It's yesterday's news now, but at the time we were taught, yeah, grief is super linear, super straightforward, 1, 2, 3, 4, 5, everything happens as it ought to. Most of my exposure, though, as an undergrad was on my placements. And so I had placements in different settings in aged care facilities, regional hospitals, emergency departments. And I saw some really big differences in how end-of-life care was delivered and what the patient's experience of the end of their life was during that time. But it was my experience whilst on placement that when I was interacting with people who are at the end of their lives, I felt like I could add really good value. Looking back, it's pretty clear to me that the reason that I could offer really good value in my interactions with them is that I had a lot of time to spend with them. I was supernumerary and no one actually needed me to do anything. So I had the luxury of time. If we go on to the next slide. Now, I've had to crop these photos or else it just is a bit of a time lapse of me going bold, but as a grad RN, my experience was really, really different. And I was taught as a grad that when you're looking after someone at the end of their life, you focus entirely on them until the moment they die. And then we have this instantaneous pivot to doing bereavement support for the family. Very time and very resource limited, of course. And it was also my experience that I got in trouble with the NUM for spending too much time with my patients. Sort of understandable in the context of having bed block and lots of upstream and downstream logistical barriers and resource scarcity out in the regions. Later, if we can advance to the next slide, later as a practice nurse, I was less involved in direct care provision for people who were going through palliative care. Really, the extent of my role was facilitating access to GPs for the LHN palliative care team and helping to organise home visits. But I felt that my contact there with my patients and their families was actually a bit more meaningful than what I could deliver doing direct care in terms of bereavement support. So my observations, if we can jump onto the next slide, thank you. Grief is something that we're all going to do or that we all do, but it's super individual. The times as a nurse where I felt I could actually offer the most value in terms of supporting the bereaved had nothing to do with nursing interventions. And that's because grief is not a medical condition. It's, for the most part, not a diagnosis. It's just a part of the human condition. Good bereavement support, we understand, actually starts before people die, subject to the availability of our resources, of course. But the other thing that I noticed is that there was this sort of shared unstated expectation that anyone that's involved in care is going to be equipped to provide people who have been bereaved with really good quality support. They're going to know, what to say and when to say it, but it's really not something that is very widely taught. So if we can jump onto the next slide, thank you. So what happens once people are bereaved? Well, conventionally, the wisdom was one death is going to seriously affect maybe 5 or 6 people. The literature, such as it is now, would suggest perhaps 10 or 20 is a more reasonable number. The nature and the context of the relationship of the deceased is also significant. There are factors involved such as the complexity, or if there's unresolved stuff in the relationship, how close we are to people. The carer role, I think, is also really significant. And as Miles mentioned, that is not distributed evenly by gender, the pressure that comes with that role. But here's another part as well, where being part of a tight-knit rural community also is going to increase the magnitude of bereavement needs. So everyone, on the next slide, please, everyone is going to experience their grief differently. Grief responses are totally natural when someone dies or when there's a significant loss. It's something that we experience physically as well as emotionally. And there's just a list here of some quite contradictory things that we can expect to see with grief. So poor cognition and brain fog is really common. We might see appetite go up or down. We might see sleeping go up or down. It's not uncommon for us to find that people are, exhausted, aches and pains. It takes a lot more effort to get moving. People can feel isolated. And this is not the Kubler-Ross model. This is not linear. We're not going to go through these things in a stepwise way. The intensity is going to wax and wane. So as a service, we kind of need a way to organize all of this stuff and figure out who needs what. So on the next slide, just got a little graphic here that describes a population health view of the experiences of grief and bereavement and what that might reflect in terms of service needs. So we can use validated outcome measures such as the bereavement risk assessment tool to figure out where our clients are landing in terms of their need. The idea here, though, is that most people are going to get through their experience of grief and loss. About 60% of people, so the estimate goes, are going to go through that experience and get through it just fine with informal supports from friends and family, co-workers, those sorts of things. In that 30% medium band, it's likely that people are going to benefit from more sort of group supports, maybe accessing some tailored information, some more tailored supports. And in the high risk, so 10% of people who are experiencing a loss are really going to need structured, possibly mental health supports. If we go over to the next slide, there is this chunk at the bottom, though. It's not to say that if someone is sitting in the higher risk part, they don't need anything else, and that sort of very specialized support is going to meet their needs. Everyone also needs everything else. So everyone who is experiencing grief needs something. Everyone needs acknowledgement. Everyone needs informal support. Everybody needs to understand what information is available to them. Everyone needs to be treated with compassion and understanding. So this is where we come in on the next slide, thanks. So Focus One Health, we are the provider for the bereavement navigation service, which is part of Palliative Care Connect. So we've got bereavement navigators standing by to take calls, and our bereavement navigators are specialised and can provide service linkages, advocacy, and help tee people up with the right information when they need it and connect with specialised services. So there is a difference between specialist bereavement and grief supports and mental health supports, but often they get sort of all grouped under this collective term of mental health support. There's also a lot of specialist resources, so things that are tailored to particular types of bereavement or particular causes of bereavement. But the most common feedback that we get from consumers is, I didn't know where to start. And that makes sense given what we understand about overwhelm and about the cognitive effects of grief. So our bereavement navigators are quite specialised in connecting people with the specific type of service to meet their need at the time. There's a couple of case studies I'd like to share on the next slide, thanks. So this is a client from the Southeast who had been receiving counselling from multiple providers over a 2-year period after losing her husband. And despite that ongoing contact with mental health supports, she described that her bereavement support needs were pretty much unmet. She also found that having to tell and retell her story to different service providers was pretty exhausting. So through accessing the bereavement navigation service, she was connected with a specialized, sorry, if we can jump over to the next slide. She was connected with a specialist grief counselor, and this is what the client describes as an inflection point in her recovery, in her progress towards healing. So she felt that the support that she received was one-on-one with her needs. If we can advance to the next slide, there's another instance here of getting navigation support, connecting someone who had been bereaved with the loss of her father and was actually referred into the navigation service by the palliative care team. She was looking for a group where she could connect with other people who were sort of around her age and having similar experiences, but again, found it difficult to find that in a time when she was already really cognitively overwhelmed. So again, with some timely connection and some compassionate follow-up, the client was able to receive this sort of unbiased and non-judgmental connection with the right service for her. We can jump on to the next slide, thanks. We can go one more, thank you. The other thing that we can do is provide some upskilling. So we've got some targeted education that we can deliver to help upskill people for having those conversations about death and dying. And this is really about developing grief literacy to be able to recognize and respond more effectively to people who we interact with who are grieving. So there are lots of services, lots of businesses, whether it's banks or councils or Centrelink or whomever, who are actually really actively involved in providing supports and providing services to grieving people. But part of our shared difficulty in having those awkward conversations is that we're not often sure what to say. And even my experience as a grad RN is I wasn't really adequately through my education prepared to deliver that. But it's actually something that we can do for one another. The other option that we've got as navigators is we can also provide grief leadership workshops. So that's more tailored for people in leadership positions to, again, provide them with a bit more of a grounding in some compassionate curiosity and some help in developing their communication skills to communicate compassionately with people who are bereaved and grieving. So on the next slide, this is where to get in touch with us. We would love to hear from you. There's a few links there. So you can get to us through Palliative Care Connect, including dialing 1-800-PALLIATE in South Australia, or you can dial the other number and get straight through to the navigators, or you can send in an email to the bereavement email address, which is also on the screen, or check out the Focus One Health website. Thank you so much.
Fantastic. Thank you so much. And thanks for demystifying this area and showing the stories around it and how everyone can connect and also get education around this area. Okay, so I'm delighted to introduce our final speaker today, and by no means the least, fantastic what's done by the Health Pathways at Country SA PHN. So I'll introduce you now to Litsa.
Thank you so much. It's fantastic to hear all of our other speakers, and I'm really glad to be here today. And firstly, I would like to acknowledge all the important work that you are all doing, and often particularly under-resourced in Country SA PHN, but I'm getting a post-Country SA, sorry. But I can hear you're getting heaps of fantastic information and resources. I would like specifically today to speak to you about the Health Pathways program. This program is actually an initiative of all three partner organisations. So next slide, please. The Government of South Australia, Adelaide PHN and Country SA PHN. Usually at this point, I ask if anyone's actually been able to access the website or if they've heard of it, but we can just pretend that's a rhetorical question at this time. Next slide, please. Basically, before I go on, what is it if you haven't heard about it? Well, Health Pathways South Australia is a free online portal. It's for any clinician or social sector health professional in South Australia with update to information to basically access up-to-date clinical management, assessment, referral, and local service information, and that's across the whole of South Australia. It's so that you can get local health information at the point of care to make the right decisions together with your patients, your clients, or your residents. It's a multi-platform program, and basically this just means you can access it either on your mobile or desktop or a tablet. Next slide, please. So just very quickly, the way that the Health Pathways model works is that it's local development, but we use base pathways from across the whole of Australia. But our GP clinical editors are based in both Adelaide and Country SA regions, and our subject matter experts who help us develop these clinical pathways are all SA based. However, we are part of a much broader international community. Health Pathways exists across Australia, New Zealand, and they're now evolving into the UK and Canada. So next slide, please. So what we're going to actually do in a moment is actually flip onto the live site. It's much better if we can get a look and feel for what it is that you'll be able to access. But when you get there, these are some of the pathways and referral pages that you will be able to look through. So in the palliative care space, we have clinical pathways on palliative care patients, symptom management, last days of life, pain medications, but we also have pathways in the older person space, including a brand new pathway called end-stage dementia. We also have carer health, health professional, self-care as well, elder abuse and neglect, older person's weight and nutrition. We have pathways in the legal and ethical space, including voluntary assisted dying, which was mentioned earlier, advanced care planning and resources for that, certification of death, and fitness to drive and licensing assessment. We also have what we call, as well as our clinical pathways, we have what I call referral pages. So basically these are lists of services, and then you'll see on our live site in a moment that they are within the 9 regions, LHNs, across the whole of South Australia. In the palliative care space, we have palliative care assessment, palliative care advice, palliative care support. And after this session, I will be cross-referencing all of those services that you've all been provided with, making sure they're on Health Pathways, but most of them I'm pretty sure are. So we're hoping to be that kind of one-stop shop. If you're not sure about some of those fantastic services that were just talked about today, they should be on the Health Pathways portal. We also have some broader referral pages. Everything from aged care support, care navigation, which includes palliative care, connect, dementia management support, hospital avoidance services, which, as we heard earlier, can be useful for people within a palliative care space, healthy eating services for older patients. And now that's not sure if that's gone blank for, oh no, there it is, and older person's mental health assessment. Next slide, please. Now, if you've got your devices with you, if you just want, you can actually register right now. I'll just give you a moment to look through that. But basically, it's free to across the whole, or any clinician, aged care professional or social services sector professional across South Australia. If you've got any inquiries at all, there's our email there. Now, I'm hoping that this will work, and I'm hoping you've all registered. And now we're going to hopefully have a look at our live site. Okay, hopefully all of you can see that. So this front page is this is the front page of Health Pathways. As you can see, some pathway updates there. So Q fever and zoonosis are some of our newer pathways that have gone live. So up the top is the navigation bar, so you can put in palliative care. This takes you to one of our pages, or also I'm going to pop on our landing page. So you can see here are some resources, including emergencies in palliative care, last days of life, pain medication, palliative care patients. I also mentioned our older persons pages. And here's a list of some of those pathways. So I was discussing before entering a residential aged care home, behavioural and psychological symptoms of dementia, carer health, cognitive impairment and dementia. And I think we will have a look at the end-stage dementia, which is one of our newer pathways. So basically, the way the pathways are set out, there's background information, assessment, management, and then the bottom is the referral section. So if we hop into any of these referral pages, you can see that if there's any statewide services, they're at the top, metro services, and then country services, including all of the 6 country regions. And just before I sign off, I'd just like to let you know at the bottom is a send feedback button. If you're a service provider and your information isn't correct, you can just click on help, send feedback and send us information at any time. That's it, short, sharp and shiny. I'd be delighted if you could have a look at Health Pathways, and hopefully it can be a good resource for you. Thanks very much.
Thank you so much, and thanks for navigating and showing it in real time, and achieving that in IT is just fantastic. So thank you for that. So you can see today we've got a whole range of things that are available. We've got people that are here and ready to connect and support people that are caring for others in palliative care. Now, just to be recognising the time, I've seen a few questions come up in the chat, and thank you so much. Can I recommend, just so we're not keeping people over time, can I recommend those people please contact Palliative Care Connect and reach out to them there and ask the questions, and they'll be able to navigate you to listen to the story that you're a particular client that you want to ask a question about, or in general, if you've got a question about how a system works, they'll connect you up to the answer to keep you knowledgeable in that area. So please reach out to them. There's a Palliative Care Connect website. Obviously, you can connect up to James and his team with the bereavement support. And we also have the Aboriginal Palliative Care Navigators as well. So that's all part of the Palliative Care Service, Connect service. And we have volunteering available in that space. We're trying to grow volunteers. I'll just do a quick shameless plug for the PEPA program. There is a South Australian PEPA program, a program for experience in the palliative care approach, which has free workshops and also placement in palliative care services. So please look that up as well. We'll send you all this in a link and provide some resources there, like we've mentioned. We do have a quick evaluation, which we'll put a link in the chat now. If you can take a few moments, we'd really appreciate that. We'll also send it in an email. But thank you so much to our wonderful speakers. Thank you to Country SA PHN for putting this on. And thank you to all of you, what you do in this space, and to all of our beautiful clients and their families and those around them to look after every one of them. Thank you and have a beautiful rest of the day. Thank you, everyone.